Just going to check Facebook very quickly. We should be streaming there any second. There we go. Any second. Okie doke. We are live and we have people joining the room already. Love to see it, so let's not keep them waiting any longer. Hello, everyone. Welcome to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNETS program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this episode and every episode, and I am a filmmaker and a writer by trade that's been working with CCF for over 10 years now. I believe I initially met them in 2011. So the years keep going on by. And in that decade plus, we have created countless videos. I stopped trying to count many years ago. Many different kinds of videos, live video series like the one you'll watch today, patient-centric documentaries, treatment-based videos, and many, many more, but all with one singular mission in mind, and that is to spread awareness and education about neuroendocrine tumors. So if you are new to the show, first of all, I want to say welcome. And the value of this show specifically, this program that we do, that we've been running for going on 5 years now, is really twofold as I see it. One, the information that you will get from our guest presenter, and two, the shared stories, shared experiences from within the community here at Luncheon with the Experts, and of course the overall community, the overall net community, which is extremely strong, extremely supportive. So you can see people chiming in already and saying hello and where they're signing on from. I encourage you to do the same. If you are new to this journey, I really, really urge you to embrace the community, and they will embrace you back. It is, like, as I've already said, extremely, extremely supportive. So welcome to the show. Before we get started, we always want to thank Ipsen Biopharmaceuticals, our presenting sponsor, for their support, because we couldn't do the show without them. And we do have this disclaimer from them, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, haven't been created or suggested by sponsors of Luncheon with the Experts. And CCF and LACNETS do not necessarily endorse or promote any of the views, opinions, or information provided in today's presentation. So here's the takeaway. Audience members should not rely solely on the opinions or information expressed by the guests, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So that's a lot of words, really only to say each case of this disease is unique. So take the advice and answers to your questions that you received today back to your home team, which knows your specific case in and out, and collectively together make the best plan and path forward for you. Okay. So today I am excited to welcome back to the show for the first time in quite a while, Dr. Chandrikha Chandrasekharan, rather. Dr. Chandrasekharan, welcome back to the show.
Thank you. Thanks, Rain, and thanks to the Carcinoma Cancer Foundation team and LACNETS for inviting me. I think it's been more than a couple of years since we did this one.
I say that lightly.
Yeah.
I say a couple. It might be 3 or 4. Okay, so I want you to give you a chance to introduce yourself to everyone else and explain the role you fill in this net community. But you have a little bit of news, because the last time we spoke, you were at the University of Iowa. What a great center. I know a lot of the doctors there in the net space, but you have a little bit of an announcement.
So yeah, I started my journey with the neuroendocrine tumor, taking care of patients at University of Iowa, which is, like you said, wonderful, wonderful center, and one of the best in the country. I was associated with them until recently. I had moved to another state and will be starting at another institution, MD Anderson, in the next few days. I still have an adjunct position with the University of Iowa, but not any clinical responsibilities there. So I'm hoping to cash in on both great centers for neuroendocrine tumors and continue, hopefully, collaborative work, in this field.
Yeah, I was going to say MD Anderson. Heard of it? Yeah, heard of it. Space. How important is it? These are two, I don't want to say iconic, that might be, but just two great standard setting institutions for this disease specifically. How important is it for a patient to seek out a specialty center, a center with these types of programs?
I think neuroendocrine tumor is still, though it's getting definitely very common. In fact, I think there's data that among the gastrointestinal cancers, like basically cancers that start in the gut anywhere, what we call prevalence. Prevalence is if you look at any given time, how many patients are living with a type of cancer. One of the highest, it's actually the highest, is neuroendocrine tumor. So the numbers are increasing, both the new patients, like the ones that are diagnosed recently, as well as the ones that are living with this cancer at any given time. So even though it's becoming more common, I guess, or it's still not something that an oncologist or a cancer team or cancer center sees often enough on a daily basis or a regular basis to be comfortable sometimes with the management. So with that, there are very certain there are nuances to managing this cancer, a little different from other cancers. A little bit more of an algorithmic approach in other cancers versus neuroendocrine tumors, very different in that sense. So given those caveats, given those differences, there is definitely an advantage to what I would call a high volume center, or more importantly, a center that has a very large multidisciplinary team from different specialties, like from surgeons or radiation or nuclear medicine doctors that do PRRT, or so. So there's definitely a huge, collaborative work that happens, which is more feasible, more possible in a large center. So I do think that's how it adds value to go to a high volume center.
Got it. Thank you so much. Okay, folks, a little bit of best practices before we get started. You can go ahead and start sending in your questions. Please do. One thing I want you to think about just helps us do our job better, which is, of course, to serve you. There's no limit to how many questions you can ask, but it does help me field the questions if you ask them in kind of short, generic chunks. We will certainly ask you if we need further information or clarification, because sometimes, obviously, that does help. But it's very hard in this format to take very case-specific questions. So otherwise, go ahead and start sending in those questions, and we will start fielding them. And appreciate everybody being here. If there's somebody not here that you think that should be, let them know. Tag them in the comments. Somebody already misses you from Iowa City, they say. Question. Okay, I got a question from Polly. Maybe a little vague, but let's take it. Polly says, "Why can't they do surgery at stage 1?"
I mean, they do, and we do surgeries as stage one. Again, the majority of the patients with this cancer, unfortunately, do get diagnosed when it's not a stage one. So, just for patients that are new, or people that are new to this, staging is, I think anybody who says a cancer, the first thing, like, okay, what's the stage of the cancer, is the next question most people ask. And it can vary depending on the cancer. So, depending on different, lymphoma, which is another type of blood type of cancer, is differently staged from neuroendocrine tumor, so on and so forth. So stage one refers to essentially often when the cancer is just located in that organ of origin. For example, if it's a pancreatic neuroendocrine tumor, which means it is starting in the pancreas. If it's just confined to the pancreas, that may be a stage one tumor. There are some other specifications like the size and other things of the tumor. So if at all we can find a patient with that situation, like, a person with that kind of situation, absolutely surgery is offered and definitely indicated. Again, there are some nuances whether or not to do surgery in some situations. For example, for if it's a pancreatic neuroendocrine tumor, which is like barely a centimeter in size, which is very tiny, there's actually debate whether, in a slow growing, what we call a low grade tumor, there's maybe no need to still do a surgery right away. And there's still some controversies about the benefit of that. But the answer is absolutely, if it's feasible, if we can find a patient in that stage early enough, the attempt would be to cure those patients with a surgery or what we would call a definitive management. Another example could be a rectal neuroendocrine tumor. A lot of people are getting colonoscopies, and so there's always a polyp or something else found that is very early. And whatever we do in those patients is a surgery or a procedure with an intention to hopefully get rid of it and not have it come back. But like I said, the majority of the patients, more than half the patients, are diagnosed when it's already spread to another organ, like the liver most commonly. So,
Got it. Well, thank you for that. Thanks, Polly, for your question. Let me know if you have another one. How do you feel about, this is my question just to set it up. Are you comfortable taking questions about histotripsy? It's very, very popular these days here at the show.
I can just give general overview, but definitely I'm not an expert. One, University of Iowa does not have a histotripsy machine. Nobody was doing it, and I did not
Hmm.
have patients personally get treated with it. So I'm definitely not familiar with the very specific details.
Hmm.
But what we know and what would be a great patient for that kind of a therapy, I mean, the advantages are how the tumor is attacked. This is specifically being tested in liver tumors, and just so the original trials was not just for neuroendocrine tumors, it was also for pancreas cancer, like the other kind. And it's a technology which basically uses some high powerful ultrasound waves to break up or shake the tumor, so like agitate it so much that the cells just lyse and die. And the cool thing about it is it's non-invasive, so it's not like poking a needle into somebody and doing like a surgical procedure. So it is
Right.
done under anesthesia. So there are definitely some great advantages to it, and recovery time and things like that. But the limitations are at this moment with the technology is the depth to which these waves, the energy waves can penetrate. So it may not be a great idea for tumors that are very large, or there are too many, or very deep in the liver, which just can't simply be reached at this time. So I think it's a very selected indication at this moment, and hopefully it'll expand. I think as we, any new technology once it comes out is always exciting. As we learn more about it, we start using it in different situations, and hopefully will benefit more in the longer run with more patients being eligible for it.
Got it. Thank
And
you.
in that sense, I would definitely say, if at all you're considering something like that, go to one of the high volume centers or that have
Hmm.
done it. This is something, again, a newer technology. One, in terms of operate, like the doctor doing it needs to be trained, like the more number of times, like any procedure. So entertain this in a high volume center. Yeah.
Got it. From Doug. Doug says, can PRRT raise cholesterol levels?
No, not directly. There's no, there are certain other drug therapies. For example, we use everolimus and some other medical drug therapies that have definitely a side effect of increasing cholesterol profile. But PRRT, the way it acts, the radioactive element, there is no direct therapy correlation for cholesterol levels. But
Got it. Okay, thanks, Doug. From Marcia, what's the relationship of NETs and Zollinger Ellison syndrome, if I'm pronouncing that correctly?
yeah. So it is, Zollinger syndrome is specifically for the gastrin secreting type.
Hmm.
So this is a type of hormone that's made by neuroendocrine cells, and so the tumors that can make excessive amount of gastrin. Again, broadly, there are type 1, type 2, and type 3 gastrinomas, as we call them. So kind of getting into the detail. It'd be a little hard to kind of combine and give a discussion on that. But is there a connection? Yes, because it is to do with the gastrin secretion. So the gastrin secretion may come in some patients because they have what we call autoimmune gastritis, which is like a form of autoimmune condition that blunts the stomach lining, specifically these cells that make the gas, and so the acid, as a reactive feedback, gastrin level may go up, and that's one type. Another type is actually there's a tumor either in the pancreas or the duodenum, which is a part of your small bowel, and that can secrete gastrin, and that can cause tumors. So there's a connection. The treatment may be slightly different. Ultimately, gastrin suppression may be one of the things that may be necessary. If it's localized, again, surgery options. If it's spread, then some of the other options we use in other neuroendocrine tumors may still be applicable. And type 3 gastrinomas are kind of the aggressive ones, and that is definitely something that's more likely to spread and more aggressive and not associated with these syndromes. And that definitely has kind of it's very uncommon or rare among the three subsets. So broadly, there are three kinds, and there's an association with Zollinger-Ellison syndrome.
Got it. Thank you. Thanks, Marcia, for your question. Next question from Shane. Hey, Shane, with the fresh profile pick. While it is a big picture question, while it's thrilling that the net space has gotten multiple treatment options over the years, do you believe that this might be leading to overtreating patients? Or, in other words, is there merit to watching slow growth over time and just waiting to act?
This is a great question. I think this is a question that we all struggle with, even as clinicians. certainly everybody needs, is welcoming of these new treatments because we need more. And the timing of when to use what is still very unclear, and what to use first or what to use next is still unclear. There are some clinical trials looking at specifically the sequence, like is it good to do PRRT followed by something or something followed by PRRT? Those kind of questions hopefully will be answered in the next few years. But this is really, really one of the most burning questions at this time, but we don't have very good answers. I do think in the beginning when PRRT got approved, there was a little bit of an over-treatment maybe. That's my personal opinion, because the minute there was a new dot or new growth, I think everybody's like, oh, let's just do PRRT or let's just do something. And now we're like, oh, well, maybe it's not necessary. So a wait and watch approach is still something very, very important and very relevant. I think we should have a very good discussion with the patient and learn from how their tumor has been behaving before this to make a decision. But on the other hand, I'd also say this, that, if the tumor is slowly growing, remember these are most patients we're talking about have slow growing tumors. When do we pull the trigger to act? That's also a little unclear. And that's probably my question that I struggle with. Like, it's been growing so and so over the past 2-3 years. Do we wait another 3 years? How do we project that? Or should we treat now to stop that from growing in the next 3 years? That's unclear. I also want to thank Lackness for putting on I'm not able to keep up with all the chats, but comments, but Lackness has been putting some great video links on relevant topics. So I encourage the patients to
Absolutely.
Look at it.
Yeah. We love to do that for everybody listening, so they're not having to jump out of the room, go to a Google, search and look for things. So we'll try to continue to put any of the resources that Dr. Chandrasekharan mentions today in the comments and make it nice and easy for you. So thanks for calling that out. Absolutely. Moving right along, question. Thanks, Shane. Moving right along, question from Josh. Are you familiar with the Ren Laboratories NET blood test, and what's your opinion on it? Might be a little bit controversial to some people. They can't find my NET from any scans, but positive Ren test 2 times now, and I have symptoms, so I'm on octreotide as of 2 weeks ago.
Not giving a specific answer to the clinical scenario, but I think most people in the NET field are familiar with the NET test. I don't know if everybody uses it or how many people use it in practice. I think it's one of those tools that has been around. Its use definitely needs to be what as a scientific community we say is more prospectively studied, which means how do we incorporate this in practice if it's useful, and how do we make decisions based on that, if at all that is information that's helpful. So those kind of questions are still not clear with this particular test. And so at this point, there are some clinical trials, again, that are incorporating this test as part of their protocol. Like, they're actually serially doing these NET tests in some of these PRT trials to look at how to correlate the outcomes or how to correlate the response based on these. So that's one way it's being used and being studied. Hopefully will give us answers on the utility. At this time, I'm definitely not using it in practice. As to the question of when you do not have a visible tumor on the scan and then having symptoms, the one thing I would mention to be sure is, there is what we call a differential diagnosis. Like, there are other conditions that are mimickers of carcinoid. And these are very challenging diagnoses to make. For example, mast cell syndrome is one of those. This is a condition where specific types of cells in your body release some hormones, not the same ones that neuroendocrine tumors release, but somewhat similar, like histamine, which can cause some of the flushing episodes and things like that. So these are what we refer to as carcinoid mimickers. And they can be challenging to diagnose. You may have to seek out like an expert in mast cell, which there are very few in the country, actually. So I would always caution patients with the symptoms that seems very similar, but not a tumor on a gallium PET or a CT scan or an MRI, and you just can't find it visibly. We just don't want you to be suffering with a symptom and not having the correct diagnosis. So for that reason, it's important to make sure that you're exploring not just based on the NET test, which is not very helpful in this situation, in my opinion. You don't miss an actual diagnosis of something else like a mast cell syndrome or something that needs to be addressed.
Got it. Got it. Thanks, Josh. And maybe controversial was the wrong word that I chose. Maybe just under discussion,
Yes, well,
under debate, right?
under debate.
Controversial might be too heavy-handed. But for Josh and everybody else, we did have Dr. Irvin Modlin on the show. I think was the first episode of Lunch with the Experts, which would have been like 4 years ago now. So if you go to the playlist and scroll all the way back to 2020 in the summer, we do have a whole show with him. So thanks for your question, Josh. From the family of Claire, appreciate you being back here. I remember you here last episode. The question is, are there therapies that should be reserved for later treatment, as in their usage could preclude other options for later treatment, in particular for mid or higher grade patients? Does that make sense?
I would infer the grade this reading is important. They're kind of referring to how fast the tumor is growing.
Okay.
Grade 1 is kind of the slowest growing. Grade 2 is a little bit on the faster growing path. Grade 3, that's the next grade. And then there's something called neuroendocrine carcinomas, which we're not going to talk about, which is like slightly different and very aggressive presentation. So I'm assuming that's what the question is referring to, mid to high grade. I guess I'll answer the first part. Are the treatments that we should reserve for later? Again, this comes down to the question of sequencing. And when we talk about sequencing, the question is, how does one treatment affect another? That's one way to answer, one important issue to address. And two, is it like side effect we're talking, or the efficacy, meaning how well it works, right? These are two questions. Definitely side effects are important. As a patient, you're going through all these treatment options. So what if you end up with a bad outcome or a bad side effect from one treatment, and then the doctor says, gosh, too bad, you got this from this treatment and then you can't get this anymore, right? So to me, when I counsel patients, that's the first thing I first look into. Listen, we got to think about that. What if something went wrong? Go down that path, and go down the path of what if it goes well. So that's kind of a good exercise to have in clinic. Sorry, I'm getting off track here. So yeah,
That's
back to
okay.
the question.
That's okay.
Back to the question of the sequencing. Like I said, that's really where the next set of clinical trials are being done to answer this better. Does it matter if you go with PRRT first and then chemotherapy, or chemotherapy followed by PRRT? And I'm bringing this example specifically because there is definitely concern based on some studies that say that if you got capecitabine temozolomide and then got PRRT, these are two commonly used treatments, then your chance of getting like a bone marrow disorder or leukemia is higher. Now, there are also studies that say the opposite, and in general, it's still only 2 or 3%. So that is the incidence of these bad blood bone marrow problems. So it's a little hard to study the risk factors involved, but certainly there are concerns which could dictate our decision in clinic. As to the other treatment options that are used, for example, embolization followed by PRRT, which is like a liver-directed treatment, there's concern if you use a radioactive treatment for the liver and then you give radioactive PRRT in the future, is that going to be too much for the liver to handle? So there's definitely, those are two instances of when this could matter, and this needs to happen, like the discussion needs to happen before you make decisions. But I don't think we have all the answers. I think I'd be one of the doctors to admit that we don't have all the answers yet. So it's okay. That's part of learning with time.
I mean, sequencing is absolutely a topic that comes up every episode. It's one of my favorite to dive into. Of course, I'm by no means a medical expert, but just really interested in that because it's so under discussion now within the community. Thank you, Claire, or if it's Claire's family, let me know if that's you, Claire. Next question from Dina. Does lanreotide cause weight gain? Is it like a steroid in that way?
It's not a steroid. It is, I guess weight gain becomes a broad topic to correlate with lanreotide. And, when you look at any medication, as you know, there'll be always less than 1% chance of something being studied. So, and by law, by FDA, you have to put out every side effect in, when you get counseled on this drug, you will get this huge paper with everything, and everything was going to be there probably. So it's certainly not a common side effect. In fact, the biggest, most common side effect is GI or symptoms like the bloating or discomfort or diarrhea. and again, that can lead to malabsorption of your nutrients and lead to weight loss or difficulty gaining weight, which is a little bit more common scenario than the opposite of weight gain. Now, on the other hand, let's say we need to monitor your thyroid function when you're on these medications. So if your thyroid function gets upset, which has an effect on your weight and metabolism, so that can also affect your weight. So not directly, but there could be indirect mechanisms or side effects like I talked about. But it's definitely not the poster child side effect of lanreotide to be concerned typically.
Got it. Thank you. Next question from Grace. Hey, Grace, good to see you. Hello, and thank you for your assistance. What is the common treatment protocols for periodic carcinoid attacks in patients who are currently on octreotide and demonstrate stable disease on scans, yet experience intermittent uncontrolled symptoms due to the functional tumors?
This is definitely a very challenging clinical scenario as well for us. So essentially, to translate it, this is definitely a patient who's well informed about the diagnosis. So everything, I'm assuming the reference to carcinoid syndrome can be either diarrhea or flushing. So and that management may depend on the type of symptom that is dominant for the patient. One thing we do is to increase the frequency of the octreotide injections, the long acting. Sometimes we even do it every 2 weeks, which is a little hard to fight with the insurance to get approval. We can increase the dose of the injections from the 30 milligram if you're getting octreotide to 60 milligrams. If you're getting the lanreotide 120 milligrams, we do 120 milligrams every 2 weeks. This is kind of like maximum suppression of the hormones to try to get symptoms under control. Then we supplement with short-acting octreotide injections that the patients can self-inject, which is certainly not something a lot of patients like, but it is definitely very effective, especially the patients that flush, to give themselves a short-acting injection of octreotide, which is short, which kicks into your body in 30 to 45 minutes sometimes, or even lesser in some patients. Another option, if it's a diarrhea predominant symptom, now this is, like I said, mostly flushing. Diarrhea dominant, definitely the use of teletristat or Zermello, which is like a FDA-approved product for uncontrolled diarrhea, is an option. In addition to things like Imodium or stronger medication called Lomotil. And then it also gets down to what is causing the diarrhea. Sometimes it may be other things besides the carcinoid diarrhea. These are the main techniques if your disease is stable but there's symptoms of uncontrol. And also knowing provocative factors and trying to use your injections timed to that provocation. Like if you're going to give a public speech or something and you get a flush because of that, because of the adrenaline surge, give yourself an octreotide shot before you speak or something. So things like strategies like that can help. There was a very easy to use injection, like an insulin injection model, Benfesia pen that was in production before for octreotide injection, may be coming back in the future. We don't know, but those are convenient modalities of self-injection in patients who have such severe symptoms after the tumor has been controlled in whatever way it can be controlled.
Got it. Thank you. Folks, if you join us a little bit late, this is Luncheon with the Experts at Carcinoid Cancer Foundation LACNETS program. We're here with Dr. Chandrasekharan, previously from the University of Iowa, but soon to be, like in the next couple of days, at MD Anderson in Big Texas. So how's Texas treating you so far?
Very hot still.
Yeah, no doubt.
And the nasty fall colors in Iowa.
Yeah, I hear you. Folks, great questions so far today. I see folks joining us from YouTube, but don't see any questions from that side of town just yet. So come on, YouTube, let's hear from you. And one last thing before we keep going, I always get a flurry of questions in the last 3 minutes of the show, which we inevitably cannot get to. So if you have them and you're a little nervous, go ahead and type it. We'll take care of you. That's why we're here. Keep sending in those great questions. Next great question coming from Susan. Susan says, is it standard protocol to not biopsy an 8 millimeter PNET for fear of causing pancreatitis?
So I'm not a gastroenterologist or a person who does the biopsy to talk about the risk of pancreatitis, but typically if you biopsy a pancreatic mass, you'd go through an endoscopic ultrasound where they put you in sedation and go through your mouth into your esophagus to reach that area, and not just for neuroendocrine tumor, but or any mass in that area, there's technically a risk of pancreatitis with that. Certainly, depending on the position of the neuroendocrine tumor, or I'm going to call it a tumor because it can be other things too, then the risk may be higher. I think the question is, do we even need to biopsy a 8 mm pancreatic neuroendocrine tumor? You know, usually an 8 mm pancreatic neuroendocrine tumor, as I referred to earlier in the beginning, like some patients can be observed when it's less than 1 cm because the risk of it spreading or having metastasis to the lymph nodes or the liver is extremely low. Now that we do have a gallium PET observation with periodic imaging for these small, very small masses in the pancreas. There are some features that may be very concerning. For example, if it's an 8 mm mass, unless I know it's neuroendocrine tumor, what if it is something else like cancer? So for that reason, I try to encourage, if it's safe, to biopsy and be sure, hey, this is a NET, not something else, because missing a pancreatic cancer, which is more ominous, would be different, right? Would be worse. So if I see a mass, which is in a reasonable position and can be biopsied, I think we try to be sure or some other form, and be reassured.
Got it.
And the fear more is, like I said, not to miss an alternative diagnosis, like a pancreatic cancer or something else, and not an indolent like neuroendocrine tumor.
Got it. Thank you, Susan. Let me know if you have any other questions. From Claire herself, for patients with significant liver tumor burdens, are there options other than steroids to manage the inflammation? Ideally, options that don't lead to weight gain or sleep issues.
I mean, we don't typically use steroids for tumor. Steroids are very commonly used in palliative symptom management. I'm assuming that's kind of what the question is leading to. This is very specific situations probably when we use that, when patients who have extensive liver disease. We may use some patients, some low-dose steroids for pain control or symptom control. The reason we use steroids in those situations is it's very quick to act. If it is going to work, it's going to work right away. And again, in those patients, we try to do a short course if at all we are doing this. A lot more use probably, I'm going to say, towards end of life. Doesn't imply that steroids have to be used end of life, but I'm just saying that's a situation where we commonly use steroids for tumor-related symptom control. But if it's pain from tumor itself in locations that are causing discomfort, traditional modalities for pain control, like whether it be opioids or non-opioids, some non-steroid and inflammatory medications, if it's safe from a kidney perspective, may also be used. And this is general, not just for neuroendocrine tumor. Again, this is like general principles of symptom management for other cancers as well. I don't know if that's what the question is asked, is referring to. I presume that's what it is.
Claire, let me know if that is accurate, and or if you have any follow-up questions. From Sean, are facilities utilizing generic Sandostatin, LAR, or Lanreotide? I have seen many people reporting their treatments not working as they should or like they used to.
Can you repeat that, Rain? Is the generic being used, or?
It says, are facilities utilizing generic Sandostatin, LAR, or Lanreotide?
The choice may depend on what the institution or they're used to. So again, if a lot of times I just start with Sandostatin because it's been around much longer and cheaper, but there's absolutely no other reason to. Some institutions may have Lanreotide on their formulary. So, for example, if you're a veteran, I used to work at the VA, and VA has Lanreotide now as the preferred formulary. So we ended up using Lanreotide for all of VA practice. So that's really what is at this point probably dictating what particular injection you are receiving for your tumor. We do sometimes switch from one to the other based on patients' related side effects. I do offer that to patients and say, listen, let's start the octreotide, but if the patient comes back like, that's a big needle and I don't like the way it makes me feel, or I just had horrible symptoms after trying it a few times, I do give them the option to try the other injection lanreotide. These are the only two available right now. Hopefully, in the future, we'll have some oral options, clinical trials going on for that as well. So that's what really dictates it at this point between octreotide LAR or lanreotide, which is the two formulations, insurance, formulary, practice. And then occasionally we make an intentional decision to go with one or the other based on patient factors or symptoms.
Got it. Next question from Jean or Jeanne. I'm sorry. Let me know how you pronounce your name. How often do you advise having a DOTA PET scan for those with stage 4 but stable disease?
No good studies, nothing specific to answer. This is kind of where the art of neuroendocrine management kicks in. I'm sure every oncologist and every neuroendocrine expert or netologist will have a different answer to that question. Sometimes I worry that we do too many in the community, like every 6 months, gallium net spots or copper spots of, like getting them every 6 months may actually not be very informative. That could lead to over-treatment, like one of the other patients asked in the prior question. Probably every time you get a PET every 3 months or every 6 months, you're going to see a blip here, blip there that's new, and then the radiology report is going to read progression of the cancer, meaning worsening of the cancer. So I would say in my practice, I try to use it a little bit more on a regular basis for patients who have bone involvement, because bone imaging is very difficult on a CT or an MRI, especially if it's bone extensive involvement. And PET CT is a better modality of looking at these tumors. Of course, when you're talking about a one time versus over the years, how do you manage this, right? So I'm going to give a patient example or a story. So let's say you're diagnosed with this cancer, you absolutely need a baseline PET CT. I mean, that's at this point a 100% requirement for any patient anywhere in the country. Needs a gallium PET spot or a copper or some kind of an imaging like that to know where the tumor is and if they have what we call octreotide receptors. But over the course of time, you're getting CT scans, and let's say it's growing very slowly, like a grade 1. In those patients, I don't think you need a PET every year or every 2 years. But certainly if they're noticing some new symptoms or their symptoms are getting worse, or if your scans are reaching a point of, gosh, it's been growing now every 3-4 years in the past, at some point in those patients, I may get a PET to get a sense of what else is happening. So that's one scenario. Another scenario, we get a PET CT, and whatever is in the liver and the lymph nodes, I can see it very well on a CT scan, but this patient also has a lot of tiny spots in the bone, which is best imaged on a PET CT. So in that patient, I'm more likely to get a PET CT every maybe not every 6 months, but at least once a year, because these spots are not being seen on a regular CT or an MRI very well. So this could be another situation. So it has to be tailored to the patient and the patient's distribution of the disease or the symptoms of what's happening. So it's really hard to answer. You need a PET once every year is definitely not the answer. The more the indolent disease, the less frequent the requirement, I would say. And then the more the bone dominant disease, probably more likely to get these PET scans, I would say. And then the role of looking at PET, whether your PRRT treatment was successful, is a different topic. And that's still unclear. What does the PRRT, how does the PET scan inform us of the PRRT in between or after treatment is unclear.
Got it. Thanks for your question. Next one comes in from Martha. I understand that lanreotide can lower the heartbeat. How often do you see that side effect, and how much lower might an already low pulse go if that's true on lanreotide? I normally run around 50 daytime, 40 nighttime with some PVCs and have not yet started the shot. So maybe there's a little bit of concern or fear there.
It's definitely not a very common side effect again. It's probably going to be in those low percentages coded. I'm yet to think of a patient that I had to say, hey, this is likely from lanreotide, let's stop it. As you look at any of these studies which involve octreotide, lanreotide, you will notice patients taking this for years and even decades, almost like 97% of the patients. Like that's out of 100 patients, you start them on this kind of drug, 97 to 98% are going to be continuing on it. Probably of being concerned and if you need it. And obviously, with any new treatment, we say, we've seen this described. It may happen. I've certainly had one or two side effects that I did not think was from lanreotide, but maybe was from lanreotide. So we are always seeing that one odd cases here and there, but it's not a common thing. That would not be a reason to hold back. Patients who are people who are very active do run a resting heart rate in the 50s, especially if you're physically active and athletic and do, some kind of a physical activity. So again, by in itself, if you're asymptomatic, not having dizzy spells and passing out, that's not a concern. I probably can't answer the question on the PVC because that's cardiology, but yes.
Yeah, fair. Thanks, Martha. Let me know if that helps. And if you have a follow-up question, question from Shane, do NET specialists such as yourself work with doctors in the lab to develop novel treatments for NETs? I'm interested in work being done targeting telomerase. How do you say that?
Telomerase, yeah.
Telomerase, specifically for the DAX, DAXX/ATRX mutations.
I mean, we certainly work, but I probably would not be able to answer that specific question. There's, the telomere. I don't know how much to explain this or how well to explain this.
Right.
Um, um, to my knowledge, there's not much right now in the advanced phases targeting this. So that would be the answer. There are
Okay.
definitely other targets being looked into in preclinical, what we call preclinical, is like in the science lab experiments being done. At least in the major areas in neuroendocrine right now in the US that I'm aware of, that's not a whole lot of focus or advances in that yet to expect a treatment from it in the very near future.
Got it. Thanks, Shane. There's a lot of activity, we've alluded to it already, going on in the NET space, and there has been for the past couple of years. Glenn asks, are there any new treatments on the horizon? Which I'm sure there's a few answers to that, but could you speak a little bit as to what's being developed and looked at currently?
So I think a lot of patients are probably already familiar with alpha PRRT, which is either the lead or the actinium or even bismuth. Those are the three big elements that are being combined with the octreotide molecule to target the patients that have the tumors that have the receptors. So that's probably the biggest one that's going on in the neuroendocrine tumor, like the low-grade tumor. There is another, target. I want to give a shout out to Dr. Heidi Delvero in NIH, who has a novel target DLK, which is like a specific protein expressed on some tumors. There's a clinical trial that she has at NIH ongoing, which is one of the new targets. There's, we are as Iowa interested in a CD4/6 inhibitor pathway. There are some clinical trials that may be coming up with that. So these are some of the drug therapeutic space and PRT space that is being explored. There's also interest in CAR T cell therapy, which is somewhat of a success in some other lymphoma type of tumors. These are very early, like what we call phase 1 clinical trials. So there's probably a while before we know whether they work, what are the side effects, whether we can use it in patients. So that's some time, a lot of time left for that. I already mentioned the oral octreotide. Even though it's not necessarily a new target, it's still exciting to have a pill octreotide version, hopefully, instead of injections and things like that in the future. So that's definitely another area that everybody's excited about.
Yeah, for sure. Thanks, Glenn. Next question from Sachin. Sachin says, can increased necrosis without signs of new tumors be a sign of regression? My only treatment is Sandostatin right now.
So this is, again, a very hard question to answer. Necrosis refers to death or dying. And when you look at a scan, a CT scan, not MRI, but a CT scan, typically these cancers look like big white ugly blobs, but then in some tumors, the center of it can look very dark, like black almost, and we could refer to as dead tumor in the center. It's like a capsule and dead tumor in the center. Now, some tumors may have this appearance to begin with. So like when you get a first-time scan, that's how they look, whatever the reason, the cancer, the way it behaves. And then sometimes we see that when you do a type of treatment, for example, chemotherapy like capecitabine, temozolomide, even PRRT, and more recently cabozantinib, which is a drug that recently got published and hopefully will be approved, These drugs can alter the way the tumors look on the scan. And so this dead center may look a little larger in some patients, or the rim that has the blood vessels may look faded away in some situations. So we always struggle as clinicians when we look at these, and radiologists too probably struggle to look at, hey, what does this mean? What's happening in the tumor actually? Now, it's not very common to see that kind of effect in octreotide or lanreotide, though, because octreotide, lanreotide is often more of a tumor stabilizer, so we don't kind of see the robust tumor killing. But like I said, even without treatment, some patients' scans, the cancer spots do look to begin with necrotic, as we use the word, meaning like a dead dark center, or cystic, more like fluid-filled spaces. And that's just maybe how the tumor is to begin with as well. So again, in these situations, time will tell us the answer as we follow along with multiple scans as to what is actually going on there.
Got it. Thank you. Mary says, can liver tumors cause pain? And some other people have commented that they've caused discomfort for them.
Yes, I think it's again not specific to neuroendocrine tumor. It's a general question. The liver has a capsule, like which is like a sheet around it, and the pain receptors in your body are actually located on the capsule, like the sheet covering. So if your cancer is located in the periphery or rubbing against this capsule, then definitely that's possible. It's uncommon, at least it's because the substance of the liver inside does not have actually pain receptors. If you just have a 2 centimeter small tumor all the way in the center, that's less likely to cause pain. So the answer is yes, depending on the location. Again, I always tell patients that when you come in and say I have pain, I'm nobody to tell you you don't have it. My job is to try to figure out where and if it is located, where and how I can help. And if it is tumor related, that we think, can we reduce the tumor to help the pain, right? So that's the answer.
Got it. Thanks. Thanks, Mary. From Sean, is it common to see tumors with more than one possible type or cells? For example, carcinoma with neuroendocrine features. Would this be two types or a mixed tumor?
Yeah, so this is a different entity. There are three entities. One is the neuroendocrine tumors, and then what we call mixed neuroendocrine, non-neuroendocrine tumors. The technical word we use is MINEN, MINEN, which is referring to, if you take a piece of tissue, 30% of the tumor is a different type of cancer, like adenocarcinoma, for example, in colon. And then 30% of the tumor is neuroendocrine elements. And these look very different under the microscope, and they can have different proteins that they stain for. So these, I guess a simple non-technical term is a collision tumor. It has two elements. That's one type. And then the third type is a carcinoma with the neuroendocrine features, which is referring to a different type of cancer, like even a breast cancer, for example, may have some elements that look like neuroendocrine tumors. So that's what is the carcinoma with neuroendocrine features. These are definitely not very common, and maybe more common in some organs. For example, this MINEN, the collision tumors I referred to, are more common in colon, not as common in small bowel, barely see them, and then less common in pancreas too. It definitely needs a very good pathologist to distinguish. All that we do as an oncologist is depending on what the pathologist reads and sees. We certainly have patients that have had pathology reviewed in, say, a place where they don't see it often, and then they get labeled as something, and then come to Iowa or another larger institution, and then get reclassified as, hey, this is not neuroendocrine, this is just a cancer with neuroendocrine features. The treatment definitely can change. Typically, the carcinoma with neuroendocrine features are a little bit more aggressive and treated like B cancer. So it's a breast cancer treated with breast cancer protocol. If it's colon cancer with neuroendocrine features, it's treated like a colon cancer, more likely. And then the mixed ones, we still don't know how best to treat them. We treat the worst element in it. So the more aggressive element is what we try to go after.
Got it. Thanks so much.
Which is another reason to go to a high volume center, because you're going to have a pathologist that's going to be able to look at it. So I think at least 5 to 10% of pathology gets revised or reread when it goes to a different, like, high volume center. So sometimes patients may not have access or ability to go physically to a high volume cancer center to be seen, but it's possible for your oncologist, if in doubt, if something is not adding up with your scans or your clinical picture, to send the actual slides, your pathology tissue biopsy, to another institution. So that's an option if you are not able to get there in person.
Well, yes, that sets me up nicely for I have a comment from YouTube from Lady RNT1 who I want to try to get some help. It might not be for you, Dr. Chandrasekharan, but I live in Michigan, cannot find a doctor that takes me seriously. Unfortunately, this is a common scenario. The endo I had was convinced I have carcinoid syndrome. Do you know a doctor here in Michigan or Ohio that you could refer? So that could be you or anybody on the back end. I just want to try to bring a little bit of awareness, especially speaking of what you were just mentioning.
I don't know if I'm going to answer the question, but I would
No,
definitely encourage the patient to connect to the local or any of the patient advocacy organization to be able to help
yeah.
locate a good physician for you with your situation.
It wasn't
Yeah.
necessarily
Okay.
for you, but for anybody who could chime in there, even the audience members, if there's
Yeah.
someone that you like in Ohio and Michigan, just because this is one, what you were just referring to, if people don't have access to these centers, and two, just a very common scenario. So we want to still try to provide some guidance there. From Larry, routing monitoring with CT and MRI has not been able to detect my NET in the pancreas and hip. DOTA PET seems to be the only effective imaging tool. In light of your previous response, do you have any thoughts on timing of DOTA PET for follow up on my indolent PNET?
So, it depends. I would say if it has not been able to be detected on a regular scan, my first question is what kind of scan was done, what is the protocol, and the quality of the scan. Again, if a CT did not detect a pancreatic neuroendocrine tumor because it's small, an MRI can be pretty sensitive and can even detect a 5 millimeter scan, and MRI is actually lesser radiation exposure in those patients. Um, and so that would be a good option to kind of explore if that's not being done in situations. So it's very unusual for, it sounds like it's very limited disease in some patients, and that happens occasionally where you're like, hey, what's this blip in the one spot of the bone doing? I would also caution that PET scans can have false positives, even in the bone. For example, if it's an isolated spot, it doesn't add up because when you have a pancreatic neuroendocrine tumor, you expect a liver, not just a bone met, like one area. So in those situations, I'll be discussing with the radiologist or nuclear medicine doctor, hey, are you sure this is that or something else? For example, something called a hemangioma, which is like a blood blister in the bone, may be PET positive and may not be tumor. So just kind of want to make sure that every scan, everything we do has a false positive and false negative. So when the clinical picture or common scenario does not add up, it's good to make sure that's not the case and be misled into that path. If indeed we are convinced it is PETs, if the only best way is modality is PET, then if it is indolent, even once a year scans may be adequate for a non-functional tumor. Again, that's a very general answer and a general word of caution on how to interpret these scans and scan reports.
Got it. Thank you, Larry. Folks at home, we have just a little more than 5 minutes left, so I'm going to keep pushing forward and try to get to as many of these questions as we can. From Jenny, how am I able to pinpoint that severe frequent pain in the left temporal lobe is result of bone mets to the skull? My primary was 14 years ago, and small intestine with surrounding lymph nodes also showed return to abdominal area. Receiving Sandostatin, but this isn't helping with pain or nausea. How am
Well,
I
I
able
mean,
to... Okay,
I will try to answer this as a general question, maybe. Like,
sure.
I can't specifically not looking at scans, but is it possible to have pain from bone involvement by neuroendocrine tumor? Absolutely, but I can also say the opposite is true. I've seen some patients with extensive bone marrow involvement and absolutely no pain. So it's very different. Typically, when pain is this presentation from a tumor, there's bone destruction, and a bone destruction is visible on a CT scan. But in some specific areas, like for example, on the tiny bones, an MRI may be more specific if it's a small area. So we try to put a PET CT in addition to an MRI or a CT focused on the area of pain to correlate that if it is indeed from the tumor. And in some patients like that, if we are convinced it's the tumor causing pain, we can also consider regular radiation. If the patient is not ready for like a PRRT or a drug treatment or something, but it's one spot that we are convinced is tumor in the bone, especially causing pain, we can do conventional radiation sometimes and maybe partially successful in controlling the pain aspect of it.
Got it. Thanks, Jenny. Hopefully that helps a little bit. Oh, dun, dun. Okay, Grace, do grade 1 tumors change their presentation? For example, can carcinoid syndrome that hasn't caused any diarrhea over many years eventually start causing it?
I try to think of medicine as and patients as not following rule books, so the answer is probably yes, definitely can happen. Maybe not very common,
Mhm.
but I think we should always have the suspicion, right? So if something changes, somebody who has tumor for years and years, and suddenly develops more diarrhea, I would do the regular rule out, what if it's something else? But if nothing else comes out, it could be related to tumor. I've definitely seen it a little bit more commonly, well, not common again, but uncommon in pancreas. So it is possible for patients to have a pancreatic neuroendocrine tumor, like we see a mass, which is, quote, non-functional, meaning not giving any symptoms, and then suddenly starts making insulin, and these patients start having insulinoma type of symptoms, like it's almost like a switch turns on in this tumor. We don't know why and how and where the switch is. That would be nice to know to turn it off. But certainly that is, possible, and we've definitely seen patients with that switching to a functional tumor type, and then treated that way. So I think there's a follow-up question that Grace also has, or is it that the tumor's biology determines the chemicals produced, meaning the symptoms don't change over time, they just progress? Again, I think there's no rule book to follow, so the symptoms may change, the biology may change, the chemicals may change. It's very uncommon, though, for example, a tumor that is, making gastrin to secrete another hormone, though. That's very, very, I've never at least seen a patient that do that. So switching chemicals is not common, but making chemicals when not making before, or switching the biology, like how it grows, that's definitely possible.
Got it. Thank you. And a special thank you to Lisa and others for chiming in about the question we had about Michigan and Ohio doctors. So appreciate that. And I see that it got through. From Martha, will the surgical management of small bowel neuroendocrine tumors, consensus guidelines on North America or on NANETS, will that be updated and available in 2024, as I read somewhere? Not sure if you can answer that, but any thoughts?
Um, Probably can't answer questions on behalf of NANETS,
Yeah,
so
I didn't know. I didn't know.
yeah, let me pass
We
that.
probably have someone in the audience that can. Sorry, Martha. We'll try to
Okay.
get you that answer very quickly. We have 1 minute left. Question from me. Um, I always like to look into the mind of someone very recently diagnosed, unsure of what this disease is, what future it holds for them. What's your first piece of advice to someone who is diagnosed this week?
Um, I would probably say it's a team effort to them and that they're not alone. That's the
Mm,
first thing I would want to
mm,
emphasize to them. And I mean it not just as a physician team, like you referenced, the wonderful community, the patient community, the advocacy, and that happens. So you're not alone in this is probably the first message. Um, no matter what, whether it's an indolent tumor or not, it is a cancer, and the burden it brings and the cloud it brings with it, the gray cloud. I don't think anything you say at that moment is going to minimize that. But I think trying to hopefully find life with the cancer,
mm.
which again, as a doctor who's not in your shoes, I'm not the best person. I can empathize, but I can probably can't understand what the patient is going through, and I just want to make sure I'm there for bearing witness and holding their hand,
Hmm.
and
No, I
give them.
think that's a perfect, very thoughtful, very heartfelt answer. I appreciate you for that. And you are not alone. That is, I think, if there's any line to sum up what we're trying to convey here at the show, that's a big one. So thank you. I appreciate you saying that. And Dr. Chandrasekharan, thank you so much for being here again on the show.
Thank you to all the patients. Thank you to everybody, not just patients, anybody chiming in, and thank you for the opportunity. And I hope to be back if there's anything I can do for the community. Thank you.
Absolutely. We'd love to have you. And thanks to you all at home for joining us. As always, we hope this program helped answer some of your questions. Thanks again, of course, to our presenting sponsor, Ipsen Biopharmaceuticals, for their support. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts, which we will be taking November off and be back to